Hello, my name is Faizan Ahmad. I'm the first year rheumatology fellow at All of You UCLA Medical Center, and today I have the pleasure of speaking to you about a case called dry eyes and tripping over tires. So we had in the fall of 2020 a 63-year-old gentleman who came in with 3 weeks of fever, weakness, and fatigue, and really weakness that was interfering with his ability to do his job. He worked in an auto body shop repairing cars, and he was noticing more so that he had weakness in his right hand. He was stumbling a lot, tripping over the tires in his auto body shop. On review of systems, he also had dry eyes and dry mouth that was really quite severe. So on physical examination, we noted that he had a fever and dry mouth, poor salivary pooling, and also a right wrist drop, right hand drop, as well as bilateral foot drop. On his labs, it was noted that he had an ANA of 1 to 160, ANCA was negative, he had a small cryoprecipitate of 0.7%, rheumatoid factor was 340, Coombs was positive, CK was in normal limits, and his SSA and SSB was negative. Also on his physical examination, his Schirmer's test was positive, with the right eye being 4 millimeters and left eye being 0 millimeters on the Schirmer's. He had CNS imaging because of his neurological deficits, which were negative, including MRI of the brain and CT of the head. He had an EMG, which showed motor and sensory loss and diffuse axonal sensory motor polyneuropathy. The differential was AMSAN versus confluent mononeuritis multiplex. He then had 2 biopsies, one being the salivary gland biopsy, which showed more than one foci for a high power field. And he also had a sural nerve biopsy, which showed lymphocytic infiltrate. So putting these findings together, he met the criteria for Sjogren's syndrome based off of his positive Schirmer's test, dry eyes, as well as his positive salivary gland biopsy. And with his neurological deficits, we're ultimately able to diagnose him with mononeuritis multiplex in the setting of Sjogren's syndrome. Subsequently, he got pulsed with steroids. He got 2 doses of rituximab, and in 3 months follow-up, his rheumatoid factor was improving, complement levels were improving, and he had near resolution of his right hand drop, but he still had bilateral feet drop that was persistent that we think will improve with time. So just want to mention some teaching points regarding this case. So mononeuritis multiplex is more commonly seen with your ANCA-associated vasculitis in about 7% of those patients, whereas in lupus, you might have it with somewhere between 1 to 6%, and with Sjogren's syndrome, somewhere between 1 and 5%. In systemic scleroderma, it's very rare and found to be just in rare case reports. And so I want to mention that positive rheumatoid factor in Sjogren's syndrome is associated with higher prevalence of articular involvement, cutaneous vasculitis, and Raynaud's, whereas the presence of cryoglobulins in Sjogren's is associated with a higher prevalence of enlarged carotids, adenopathy, cutaneous vasculitis, peripheral neuropathy, and Raynaud's. So I just want to close with emphasizing the fact to keep in mind a broad differential when evaluating a patient with mononeuritis multiplex, as it can be the presenting complaint in ANA spectrum diseases. And I also just want to mention that some of the treatments for this condition and neurological disease in Sjogren's syndrome is cyclophosphamide, IVIG, rituximab, and plasmapheresis in combination with corticosteroids. Thank you so much for listening, and there will be more presentations coming up for RWCS. Thank you.